Muchos países alrededor del mundo se han
Many countries around the world have committed to advance towards universal health coverage, which involves providing all health services required by people with quality and without financial hardship. But we are still far from achieving that goal. Millions of people have serious difficulties in accessing the healthcare services promised by the governments or face serious financial issues when it comes to having access to the services and medicines they need. These situations are due not only to a lack of resources for healthcare, but also due to huge inefficiencies in the sector spending. It is estimated that 40% of resources are wasted as a result. Can you imagine what could be achieved if the inefficiencies were to be reduced? The mass online course, What to Finance in Healthcare and at What Price, tackles this challenge. Accompanied by the best specialists on explicit health prioritization, benefit plans, and tools for drug prioritization, along with key experience sharing, it'll be possible to further better decisions that will help countries move towards universal health coverage and achieve more health for the population. We would like to invite you to register to take part in this course. Good morning, everyone.
English-speaking audience, we have enabled simultaneous interpretation so that you can access it by clicking the globe icon at the bottom of your screen. Me dá mucho gusto darles la bienvenida. Mi nombre es Marcela Distruti y soy
A
especialista
warm welcome. I'm Marcela Distruti, a health senior specialist at the IDB. We are very pleased to share with you the results of two studies we have conducted on matters that are very important to health in the region, and also to see how to better deal with health spending. The use of unbranded generic drugs. And these studies in Chile and the Dominican Republic have estimated the improvements that can take place in households and in healthcare systems. The results for both countries are truly impressive. Through the chat, you will be able to see links to download these studies in Spanish. The English language versions are being prepared and will be available over the next few days. This session will unfold as follows. We will start with an interview with the main author of these studies, Juan Pablo Tal, and Catalina Gomez, one of the co-authors of the studies. Of course, this has involved Pamela Gongorra, a senior associate at the IDB, and we will now hear some comments by Jaime Spiel and Natalia Jorgensen, also co-authors of the studies at the end, and depending on time, we'll have a brief Q&A with all of you. So to get started, I would like to briefly introduce today's guest. Juan Pablo is an economist and academic and is currently an assistant professor at the University of Pennsylvania. He got his PhD in economics by Yale University and a degree by the Catholic University of Chile. He has published in prestigious academic journals and has received multiple recognitions for his work, in addition to scholarships and research awards. Catalina is a senior economist with over 15 years' experience, offering technical assistance, analytical tools, and advice to governments in Latin America and the Caribbean, NGOs, and international development institutions. She has a PhD in economics by the University of New York and a master's degree in economics by the University of Los Andes. Jaime has a degree in law by the University of Granada, has a master's degree in health economics and a doctoral degree in economics. He's a professor at the Andalusian School of Public Health. He has been a visiting researcher at universities, including LSE, Columbia, Chicago, and Harvard. And we have our also guest from the healthcare sector, who is a specialist on policy design and implementation in Latin America. I would like to also invite you to feel free to share your questions through the Q&A icon, and that you will find in the lower part of your screens. Thank you very much for joining us. Pamela, the floor is yours. Thank you, Marcel. And good morning to all of you. It is my pleasure to be here. As Marcela said, the topic here is unbranded generic drug substitution, a very important topic for our region. So it's a pleasure to have an opportunity to learn from these two cases involving the Dominican Republic and Chile, not only because health spending and spending on drugs continues to have a growing share of spending, but also because it is a particularly topical matter around the world. So the idea is to focus on each study, see how they have been conducted, and I have a few questions. We'll conduct this in the nature of an interview, and I would like to start with you, Juan Pablo, and ask you about the methodology. And could you perhaps tell us what drove this research and what the relevance of this is to the region? Well, thank you for the intro and for the opportunity to be here with you. Let me share my slides with you. So basically, we're here to look at policies to improve health access for the region's population, as mentioned in the video, and also looking at policies on drug access is a very important matter because medicines are a very important share of out-of-pocket expenses. And this applies to Chile and to the Dominican Republic as well. The thing is that there is low penetration of unbranded generic drugs in these countries. In Chile, 30% of market share for unbranded generics. So there's 50% for branded drugs, which are much more expensive. Yet this is low if compared to other countries, as in the States, where 90% is for unbranded generic drugs. So this study asks a pretty natural question. How much would households save or healthcare systems save with full unbranded generic drugs substitution? Thank you, Juan Pablo. We always talk about generics and non-generics, but there are also branded generics. This is very interesting and something that applies to all of our countries. Could you also tell us about the methodology you used to estimate the potential savings for countries? Well, the idea is pretty simple. We consider a market where the quantity of the branded medication, the branded drug, which we will call QBM, is taken into account, and we consider that the unit price of the branded drug is PBM and the unit price of the unbranded drug is PGM. So the potential saving on the market is about how much lower the spending would be if this whole consumed amount of branded drugs goes into unbranded drug purchases. So this would be the unit price multiplied by quantity, and then you get the difference. By way of example, here's a table also showing the structure of the data we use, which is IQVIA, using some fictional figures, but it helps somewhat understand the methodology. So here we are talking about cefadroxil, which is an antibiotic. It is an oral suspension, and we have 4 products that are branded and 1 that is unbranded on this market. So the data we use reflect the sales and the price as well. So the potential saving needs to be calculated on the basis of a set of steps. First, there's the market definition. I'll come back to this in a moment. And secondly, for each product, we extracted by decoding the text the total active ingredient, the number or the quantity of mg. So the first product has 500 milligrams every 5 ml, and then you get 10,000 mg. And based on this, you can calculate the unit price for each product, the price per mg. And the unit prices for the branded and the generic drugs are calculated as a weighted average for each segment. In this case, this fictional example is the weighted unit price of the drugs, which would be 2.4 pesos per mg, and for the unbranded generic, it would be 0.7 pesos per mg. Then you add up the total consumed amount of the branded medication in mg. This would be 4.5 and then 10 to the power of 8. And you can then see down below 775 million pesos as a potential market saving, which would be 800 in dollars. And the total savings would basically be about repeating the same exercise for each market and then adding up throughout the markets. Before showing the results, I just wanted to share some highlights. Market will be defined as a combination of the active ingredient, presentation, administration mode, and pharmaceutical form. It could be cephadroxyl oral suspension, conventional release. This will apply only when generic alternatives to the branded products exist on the market, a point I will come back to later. This assumes that the total consumed amounts remain unchanged in the context of the substitution. And saving is quantified based on current price differences. So you could perhaps envisage policies that could encourage or force substitution and change prices, but this would require a fairly more complex analysis than the one that was carried out. So, one point is that you can actually express the equation, the potential saving, in an alternative and fairly intuitive way using algebra. But the idea would be that the potential market saving could be expressed as the multiplication of three terms: the percentage price difference between branded and generics multiplied by Q in terms of the market share for branded and market size. And this is interesting because it helps highlight the fact that potential saving will be higher the higher the price difference between branded drugs and unbranded generics, the more branded drugs are used and the larger the market size is. So I can now move on to the results. If there are no questions, yeah. We'll answer questions at the end. So unless we have anything specific to address via the chat, but otherwise I think we can just wait until the end. You can share the results, tell us what the savings were for Chile in this particular case, and I'm going to take the Chilean case. The focus of this study is outpatient treatment drugs bought in private pharmacies, and the total annual sales for these are in the region of $2.3 billion annually. It should be noted that in Chile, there is very low financial coverage, whether it be public or private insurance for buying the drugs from these private pharmacies. In Chile, we detected 189 markets or 155 active ingredients with the potential savings. So we have a coexistence, the branded and the unbranded generics. And the total sales in these markets amounted to $660 million approximately. And two interesting details about these markets. The price differences between segments are very significant, 6 times. So on the average market, the unit price for branded drugs are 6 times higher than for unbranded generics. And despite the huge price differences, the market share of branded drugs is high. And it's about 48%. That's the market average. And of course, there is a dispersion in the market. There are some markets where there's a larger or higher, and others in which there's a lower share of branded medications. The combination of the information revealed a potential saving of $316 million, which accounts for 48% of sales. So the IQVIA data was combined with the Chilean National Health Survey, and this helped estimate what part of savings would go or benefit different socioeconomic groups, looking at education and insurance type. For all groups examined, the saving is approximately 50%. And this is partly due to the fact that the market share of branded products is quite similar across the different socioeconomic segments considered. So the policy could have significant impact for the benefit of all socioeconomic groups. I will now move on to the case of the Dominican Republic. It was the same focus in this study with the outpatient treatment drugs. Total annual sales are $660 million. One difference relative to Chile is that there is coverage. Most of the consumers here belong to or are in the contributory scheme with coverage of 70% as the cap. In the DR, we detected 258 markets with potential savings. These markets have total sales amounting to 272 million a year. And there are also price differences between segments that are considerable, although less than in Chile, 3.5 times. And despite the price differences, which are significant, the average share of the branded drugs is still high, about 70%. The potential saving, both for insurance and households, so the aggregate was $122 million, or 45% of sales. Due to data issues, we had to work on the basis of several assumptions to decide what part of that would go into the, or the savings would go into the households. And it's estimated that a significant part of this would go into households, and the rest would go to the insurance. So we would be talking about between 11 and 49%. I just wanted to put the figures in context and highlight the lack of generic alternatives, a factor that considerably restricts or limits possibilities for substitution. 100% of this pie is the total sales of outpatient treatment drugs in Chile. And what you see in red is that markets that offer substitution opportunities, the ones we discussed earlier, account for about 30% of the total pharmaceutical market. Also worth noting is the fact that a significant share, actually what is shown in yellow, relates to markets with no possibility for substitution, but where there is at least one branded generic drug, which points to the fact that these markets are off patent and that there could be unbranded generics and, of course, a potential saving through substitution that will be much higher. So this is an initial and additional exercise to quantify a significant share of markets. And there are also markets with innovations in the field that are also off-patent. So the off-patent markets, but without the substitution possibility, those account for 62% of the total market. So there's a very significant share, 62% of the market, where we could achieve much higher savings if there were to be generics. Well, the situation in the Dominican Republic shows that at least 48% of the market could offer substitution possibilities leading to higher savings if there were to be unbranded generics on those markets. So I'll stop here. This suggests that potential savings could be even much higher. than the studies suggest. And here we continue to talk about the outpatient treatment drugs, right? Yes. So there could also be savings for the other category of drugs or the inpatient treatment drugs if efficiency gains are achieved, right? Yes, absolutely. Thank you. You're welcome. Now, I would like to move on to Catalina. Thank you for joining us today as well. Juan Pablo talked about the savings, and he also gave us figures in pesos, so in terms of money. And what about the opportunity cost? It would be good to hear you tell us what this suggests in terms of opportunity costs. Thank you, Pamela and Marcela. I love to be here sharing these studies we conducted, which I think highlight some very interesting results for the region. I think the way you presented this is very interesting. We're not talking about spending less, we are talking about spending differently. It's not that we don't want to spend the resources. We want to spend them on other things to buy more health. And I'm going to share a few slides with you to try and make the presentation easier. What's the opportunity cost? That is the benefit we could have received, but the one we had to forego as a result of having taken another course of action. So every decision we make has an impact in terms of what we haven't done. So for households, what is the opportunity cost? It's how much you could have bought with the money, the extra money you spent as a result of buying the branded drug instead of using the generic. I could have bought more food. I could have bought or paid for more transport or recreation. That's the opportunity cost for households. So the spending that did not take place in other areas or on other items. And we measure things in terms of the net health benefit. In other words, additional life years gained. So generally speaking, the net health benefit is the additional health offered by drug B compared to alternative treatment A, minus the health level that could be achieved if the necessary additional resources to finance drug B were instead changed to improve the opportunity and access to the health system. So on the left-hand side, you can see the health gain as a result of a new technology, B, or drug B, minus what we call AVAC, the quality adjusted life years, times the number of consumers. For generic drugs, this will be close to zero. Generic drugs, if they are of good quality and successfully undergo all health agency trials, should offer a benefit. There's also the loss of health due to disinvestment in other technologies. So we have the cost of drug B and the difference between the cost of price of drug B minus the cost of benefit A. That is the saving I could achieve by using branded drugs without the generic drug substitution, as Juan Pablo showed, multiplied by the number of consumers divided by a unit, which is the cost effectiveness threshold. That is to say, the price of a life year lived in perfect health. That is technical calculation based on the health gains to be had in a country as a result of the spending. So it's a price of a year of life, and it is quality adjusted, adjusted for quality. And the last term on the right-hand side of the equation shows us what is being lost in health as a result of not spending those resources within the health system. So those are basically our calculations. Great, Catalina. I think these are the clearest explanations I have seen of the opportunity cost. I understand that you also did calculate some of the coverage cost implications as well. And this with a view to looking at the situation of the population as a whole, given the gaps as well that exist. Could you tell us a bit more about that? Yes. When we started to review the methodologies used to estimate the opportunity cost, which is what you can see here on this graph, we realized that these are methods that are designed for countries that do not exhibit significant gaps in terms of essential service coverage. Essential services are highly cost-effective services. For example, diabetes control, screening. These are low-cost interventions that save many lives and improve the quality of life. When you look at the cost-effectiveness threshold, that is calculated as the price or spending that, on average, a country pays for a quality-adjusted life year, as I mentioned. For example, to have one quality-adjusted life year or 1 year of life lived in perfect health, an average country spends $10. So the threshold is $10. So why do we use the average price in the previous formula? Because there's no way we can anticipate what services will be displaced through financing the branded drugs. So it makes sense to assume that if we reinvest that in the health system, it will be spread on an average basis, and that way we will be able to find out how much more we can buy in terms of population health. This works nicely for developed countries, but in countries like ours, we have gaps in the coverage of essential services, and we know that those resources could help cover those gaps. So it is important to consider that we could actually say, okay, let's take advantage of the savings and use them to close gaps in essential services. So that way you can calculate how much health you will win by closing those gaps. And that's basically what we have done. In the Dominican Republic, for instance, and I will show you the results, we found that the threshold method underestimates the opportunity cost significantly, or the estimated opportunity cost using the threshold. That is significantly lower than the gap arrangement. So if we use the resources to close the gaps, we would have much higher health gains than if we just use them to improve the opportunity and the cost of the services we have.
I think that we are still seeing the slide with the formula. I think you have another graph which you may want to show us before we move on to the results. We'd like to know what these benefits are in terms of years of life and also quality. For some reason, I'm not able to move on to the next slide. Here we go. What we are doing here is showing the opportunity cost for Dominican Republic using the threshold method. So I can show you the savings to be gained by applying the threshold method. So using the same equation from the previous slide, we applied the formula to find the potential savings using the method Pablo displayed. And for 2019, the cost to the Dominican Social Security system could be up to 18,000 quality adjusted years of life, and at a minimum 4,000 of those. Why this wide range? Well, because as Juan Pablo explained, we calculated total savings, but we had to apply different assumptions to see how they would be distributed across households given the contributory system in Dominican Republic. So this is the range we found for the Dominican Republic when looking at the threshold method and the opportunity cost. So this means that at a minimum, there would be a savings of 14%. This is for outpatient treatment drugs in Dominican Republic. So this is against the backdrop where resources are distributed using a distribution, an average distribution, so that would be a savings in the order of 14%. What happens with Chilean households? As Juan Pablo said, the direct expenditure by households is 32% of total spending, which is one of the highest in the region. And for outpatient services, it is 10% of out-of-pocket expenditures. Savings are estimated at between 12 and 18%, means that households would be able to save 10% on what they currently spend on medication. This would be even higher for those households which have lower level of education. The use of generics could lead to a reduction between 12 and 18%. So in terms of additional consumption, we estimated how much more they could spend on food, on recreation, on transportation, and one of the results is 2 months of transportation expenditures could be covered by Chilean households if they were to have this type of substitution, if this were a possibility for them. Now, turning to the impact of these savings for the Dominican healthcare system using the gap method, assuming the resources are used to fill gaps, gives us some very interesting results. We took 2 services, timely cervical cancer detection and detection and management of diabetes in at-risk adults using blood sugar test, blood pressure testing, lipids, among others. This does not cover everything that is required to treat adult patients with diabetes. We found that with these, or for these services, we would be able to cover 100% of the gap for early cervical cancer detection and 59% of the existing gap in the detection and proper management of diabetic patients. So what happens if we fill that gap? How many additional years of life can we achieve? We know, because we have studies that do tell us the benefits of early detection and how many years, additional years of life can be achieved by addressing cervical cancer and diabetes. So we took those numbers and multiplied it times the number of people having access to these services if we fill the gaps. And we found that the years of life in perfect health, using the lower end potential savings for the contributory system in the Dominican Republic, would be approximately 12,400 years of life, and these are quality adjusted years. This methodology is a new methodology. It had not been used before and was not factored in for healthcare decision making. So this information is significant. Thank you. So this information is useful for decision makers, and it's important to convey the message that substitution can make a huge difference. So what are the main conclusions you would draw from the study? You're presenting estimates based on your calculations, but based on all these analyses, what would you say are the main takeaways that would benefit these countries and also the entire region? The first thing I would say is clear that there's a huge opportunity to improve healthcare by shifting to unbranded substitution. This would improve the quality of services we currently have and also would help fill the gaps for specific services that are essential. So it's not savings for the sake of savings. We're speaking about better spending, improving spending. These are opportunities that are there and that we are not taking advantage of. There's also many ways to reduce out-of-pocket expenses. We looked at Chile, also at the DR. There can be significant savings for households when they cut their out-of-pocket expenses. And this is one step on the path to universal coverage. Households do face constraints, financial constraints, when trying to access services to meet their healthcare needs. Also, it's important to look at the unbranded markets in the region. Juan Pablo said that there's space for this. There are markets with branded and unbranded drugs, but it's important to allow the entry of generic drugs that are available in both countries. So I think we need to work to promote the entrance of unbranded generics to the markets of the region. Also, another essential element is guaranteeing the quality and efficacy of these generics. Everything we are doing, of course, is premised on having quality drugs that and systems that will ensure that unbranded generics will meet the quality and efficacy standards and that they can be adequate substitutes for branded drugs. And it's important to keep strengthening the agencies and procedures in place to ensure the quality of these products. Thank you. Thank you very much. So this is important for countries and for the entire region. Now I'd like to turn to the substitution possibilities, and we'd like to look at the experience of a number of countries in this connection. Good afternoon, Pamela. I'm delighted to be here with the colleagues. This is very important. As Catalina said, the idea is not spending less, but spending better to improve the efficiency of spending. Let me see if I can share my presentation. So we all know what happens. We do want to achieve a universal healthcare system, and medicines are a key part of this. On average for Latin America, this accounts for 20% of expenses, and we like to compare ourselves with the OECD countries, and we can see that drugs account for a significant percentage. If we spend $100 on health, of that, 25% goes to buying medicines. And we know that generics can be a key element to improve efficiency. I like this graph, even though it's somewhat old. It's very useful. It shows how competition can bring down prices and increase the availability of generics on the market. So this is a key message for regulatory authorities. We did to do everything possible to have more drugs on the market. There will come a time when Unit 19, where what you see there will just be the marginal cost. It won't make sense to do anything else because the price cannot drop any further. But when you have a competitive market like the US, 10 to 15% of competition is essential to ensure efficacy at a lower price. And what we've seen in recent years, and we have many reports showing this, it's done using the high methodology, we can see that branded medicines are much more expensive than generics. We've known this for quite some time. It's nothing new. But we know, according to the study, that they can cost up to 300% more. the difference might have been smaller in the case of Chile and Dominican Republic, and it tells us that in low-income and middle-income countries, the difference between the two categories can be up to 300%. I like this as well. We see here in the statement that healthcare systems are inefficient, and we have to find those inefficiencies and correct them. And to do that, I would connect this WHO report and an OECD report. Both look for the causes of inefficient spending in healthcare systems, and one is the pricing of inputs. And it mentions generics versus branded drugs. And for me, here in Europe, to speak of branded or unbranded generics is something which we dealt with many years ago. And if you look at the OECD page, you will see that there isn't much difference between branded and unbranded drugs. And it's because healthcare systems cover their cost regardless of their classification. In countries like Spain, we're not as interested as whether they're branded or unbranded. We do want to have as many generics as possible on the market because that fosters competition. WHO issues guidelines every 8 to 10 years. This one dates from 2020, and it provides guidance to countries for designing their policies. And here from this 2020 version, there's a reference to biosimilar generics. We're going to focus on the use of generics. Biosimilars has a specific meaning, but the report is quite clear. It is important to promote the use of quality generic medicine. And turning to substitution, which is the topic for this seminar, there are two key ideas I'd like to share. The first is that legislation has to allow substitution. There's some countries where this is not possible yet. And the second is that the medicine should not be identified by its branded name, but rather by its composition. So instead of prescribing aspirin, we should be prescribing acetylcholine acid. We should use the chemical name. And this is important because if we look at the European context, which is often used as a reference, we see that almost all countries, and you can see them here in dark or light blue, either have mandatory requirements or guidelines that require the use of the active ingredient name. And this is important because when you go to a pharmacy, at least in Spain, the legal obligation is to dispense the generic or the product which has the lowest cost. And that could be the branded product. And that can only be done if the prescription specifies the active ingredient. Generics are not biosimilars, and it's important to make this clear. We see this because for biosimilars, there's a very different situation in Europe. Their status is very different. Some are medicines that are similar, but may be much more complex. Since 1993, there's a study by Cherek, and we are familiar with the Cherek paradox, and it's that when the patent for the original medicine is about to expire, its price goes up. And this is because there are many patients who are brand loyal because price is not an issue. We often hear the reference to there's no price for health, or because there is consumer preference. And I like to show this comic strip because we often think that what is cheap is not good. as Catalina was saying, I think it is important to ensure that we do have regulatory agencies who are ensuring the quality of drugs, and quality should not be an issue when we look at price, if that is the case. But if we connect things that have a low cost with a lack of quality, then substitution will be more difficult. In most European countries, I would say that 26 of our countries have a reference price system, and that offers generics at branded prices. I could use Spain as an example, as well as other European countries. When a patent expires, there's a reference price system which opens up. It is not a pricing system, it is a reimbursement system, and it says that the physician has to prescribe based on the active principle and that the pharmacist has to dispense the option that has the lowest cost. And most of the countries, that is 26 of the 27, have a system of this sort. So when the patent expires and you go to the reference system, the healthcare insurance system will fund the lowest cost option. If I go back to WHO reference pricing, there's a chapter on international reference pricing, and it states that it is recommended to use the reference pricing in conjunction with policies to promote the use of quality assured generics. So we need to have two instruments as part of our policies. We need a supply side policy, and this means interreference prices, and we need to have a demand side policy, dispensing or based on active ingredient and providing the most efficient option. So there has to be public enforcement, there has to be oversight of quality. You can find this on the web page of the Ministry of Health in Spain. They have to have the pharmaceutical efficacy, quality of generics. The idea is to ensure that branded or unbranded generics, especially the unbranded ones, which face acceptance hurdles, have to be covered by a quality regulatory agency, and they should be promoted as being as effective as branded drugs. I could say much more, but I don't want to take my colleagues' time. Regulatory agencies play a key role in guaranteeing quality. And it's not just the regulatory agencies, the ministries have to play a role. They should foster the entrance of generics into the market, because more competition brings lower prices, and we need to look at the international experience. It's clear generic medicine benefits the healthcare system. It also benefits the patients. Thank you. That was a very good presentation. I'm very happy to have heard you talk about policies, because that is important when we're looking at these studies. It's important to see how we can apply their findings. In view of the challenges we face in the region, I'd like to add Natalia Jorgensen before we open up the chat to the audience. What are public policy decisions in the Latin American context that would be important to ensure the feasibility of substitution policies in our countries? Why are existing policies not implemented? I would take the opportunity to congratulate you, Pablo and Catalina, and the other authors for this outstanding study. I think it's very good for the region, and it's very useful information for us as well. Thank you very much for inviting me. This, like other things, is a process. It's a journey. We have talked to you and also Ursula about this in our meetings, and the starting point has to be a political decision. 3 elements have been mentioned. I don't want to repeat them, but I do think they are important. One is the political will. There has to be a decision, and I'll explain what elements I think should be a part of that. The other is the perception of quality. It's not just quality, and having a regulatory agency guarantee the quality of generics in order to create these markets. It's also important to address the perception on the side of doctors, patients, and patient groups when it comes to the quality of generics. And then there's also incentives. As far as the political decision is concerned, as Catalina and Jaime said, we need to have both supply and demand side policies authorizing the use of generics, also regulatory agencies that are robust and have the necessary tools to ensure the quality of these drugs on the market, and then having supply side promotion. On the demand side, we also need some changes in regulations and how they're prescribed using the name of the generics. In my country, Argentina, early this year, there were efforts in the second article of the existing law does reference the use of the generic name, but also allows for the use of the branded name. There were efforts to remove this clause from the law, but it was not possible due to pressure from various groups. And that is why things remain unchanged as far as this law is concerned. So these pressures are there and they will remain in place, and that is why we need a political decision. This type of study is extremely useful in helping us to work on such decisions, especially in a context of limited resources as the context that prevails in Latin America today. We are making efforts in Argentina. We worked on a small scale at the province level, but we do estimate the savings of substitution of branded drugs by branded generics because we have few other options in the country, and our estimates indicated that potential savings were 35%. And we took this information to the governor. Also, we presented the information to the minister and other authorities, and with this information, they can make better decisions. This is only at the province level, but the regulations were amended in order to help improve resource allocation based on this finding. So that's very important. The second thing we need to address is quality perception for two reasons. First, we do have interagency contacts, and we know that there's an issue of trust. Patients believe in their doctors. Doctors have to trust the regulatory agency and what it approves for marketing. And in addition to having a strong agency, we need to have good communication to help improve the perception of quality of generics and branded generics so that they can be more widely accepted by the population. At least that is my humble point of view. I do think it is important. And the third point, the other thing I think is important, and this has been mentioned, is having the right incentives, either in the standards or the funding sources. It's important to look at coverage, whether coverage is for single drugs or whether it's based on active ingredients and active principles. Coverage is important, and that has to be addressed with the prescribing physicians. Having incentives in place can help us spur the development of generics in the generics market in Argentina. It's not going to be an easy road, but I do think that our budget constraints are making this very pressing because we have very little room for the inefficiencies we still find in many countries. Thank you. Thank you, and thank you very much for sharing those thoughts. I now would like to go to Maricela so that we can also go to our audience. I know that we're short on time. Marcela? Hello to everybody once again, and thank you to all the presenters for a very interesting series of presentations. I agree with Natalia in that the results are impressive and they can be very helpful to promote a discussion as well as policies that will help us increase the use of generics in the region. As Pamela said, we are short on time. We have many questions about the methodology and the studies, but we also have some interesting questions that focus on the public policy aspect and how they can be used to promote generics in the countries. I'd like to focus on two of these. One question that came from different participants is how can countries promote the entry of more unbranded generics to increase competition, as Jaime suggested? What kinds of policies, what kinds of changes in the legislation could be helpful in promoting more competition by increasing the number of generics available? And then there's also the issue of pharmacies and what kinds of policies are required. In addition to working with physicians and with the population, we also need to involve pharmacists and pharmacies to better promote the use of unbranded generics. So those are the two questions I will put to our panelists, and we'll invite them to raise their hand if they would like to answer. Jaime, I see that your camera is on. Marcela, if I could, I have many thoughts, but one thing is that for medicine to be marketed, fees have to be paid, and usually they're paid to the regulatory agency so that they will analyze the drug, maybe do away with those, so countries can authorize the use or entry of medications without requiring a fee for their assessment. That's just one. I can think of many others, but I'll stop there. So one is not having any fees for registering medications at the national level.
Thank you, Jaime. Would any other speaker like to take the floor? Yes, along the same lines as Jaime. And also, going back to Natalia, the importance of confidence in the drugs that will itself boost the demand for generic drugs. And there are several questions relating to quality. There is a significant difference between Chile and the Dominican Republic. Chile has advanced in terms of bioequivalence requirements, not the DR. And one thing that underlies this is certainly quality, as Catalina said in her presentation. I think it's a necessary condition to advance all the other policies, and that will per se increase confidence on the part of consumers and also physicians vis-a-vis the generic drugs. Thank you, Juan Pablo. It's true that confidence in generics and the quality perception regarding the generics was also something that the participants highlighted in the Q&A. And based on your experience, is there any country in the region that has adopted a good communication strategy or launched a good communication campaign so as to receive the perception that the population may have in terms of generics not having the same sort of quality or being less effective? Any examples in the region? Yes, go ahead. I would say that one of the failures in the Chilean policy was the progress in regulations, but without the effective communication. Bioequivalence requirements should have been coupled with a campaign. As Juan Pablo said, the Spanish case is a good example. This is something that has taken a long time. So I think one could approach it differently. But I mean, once the bioequivalence requirements are in place, because you can't enhance trust on the part of physicians or encourage generic drug substitution if we don't have that. Yeah, clearly. Would any other speaker like to make any additional contributions? Juan Pablo has highlighted a key point, the issue of bioequivalence, right? But I've been able to travel across the region. I've never seen any health centers or hospitals with the kind of posters or ads we had in Spain explaining to people that the generics were the same as the branded drugs. So, you know, people could use the waiting time while waiting for the doctors and read the information. And this is something that I have not seen in other countries in the region, not only in the health ministries, but elsewhere. I think it is important to raise awareness, but this needs to come once you have the bio equivalence guarantees. And there's also a lack of information, oddly enough. The campaigns are really very necessary. So sometimes the prescribing doctors themselves, you know, it's not just about the population, but the doctors that prescribe the drugs. So the idea is, if such a brand is working well and it has effectiveness and it's working with your patients, this means that the work with the doctors is important. Some countries have also made this mandatory. In Europe, some countries have had financiers who have decided to go for substitution, and progress has been made in that way. But I don't think that would be feasible in our Latin American countries, perhaps lengthier road. But if we have the foundations well established, then it's more likely to succeed. Excellent, great comments from all of you. Catalina, anything else you'd like to add? Otherwise, I think we would just wrap up. Well, perhaps along the same lines as Natalia. One alternative that should be discussed and on the table to encourage the entry of unbranded generic drugs is by offering an interesting share of the market at a lower cost. We've invited them to participate in the Colombian, Chilean, and Dominican markets, and the idea is, of course, that we can guarantee, for example, 60% of the sales. So these more radical, disruptive approaches should also be considered. And that way we could offer the best price. Yeah, centralized procurement or purchases, that's important. And one last question. I'm looking at the QA and the questions coming in. Many participants say that in their countries, the health agencies are not yet successfully guaranteeing the quality and effectiveness of generic unbranded drugs. Are there any experiences of initiatives that could be undertaken at the regional level based on your experience so as to contribute to this exercise? Marcela, I would refer to mutual recognition. If a generic has been approved by the FDA or EMA, it should be offered a streamlined fast-track procedure for approval in other countries in the region. So basically, if you're approved by the FDA or the EMA, the bioequivalence or equivalence is guaranteed. So that way, you could automatically let them in, and that would be an incentive. This has happened in some countries in the region, so I would consider that as one short-term policy. Good point. Dear colleagues, I'm being urged we need to start wrapping up our session. So once again, I would like to thank you very much, Juan Pablo, Natalia, Catalina, Pamela, and Jaime. Thank you for sharing your experience with us. And I would like to thank all of the participants for joining us. And one thing is, please read those studies. I think the link is on the chat. And you can also register for a course, What to Finance in Healthcare and at What Price. This is the Social Protection and Health Division of and Social Protection and Health Division of the bank that is organizing that. This deals with express prioritization, among other things. The link to the course is there. We invite you to register. It's free of charge. And with that, I thank you once again and wish you a great day. Thank you and goodbye.